So welcome everybody. I am Kendra Neilsen Myles. I am the Executive Director and Founder of EDS Wellness, and I'm here to specifically welcome the Metro DC EDS and HSD members of the local support group. I'm here to kind of host the virtual support group meetings as a collaboration and as a help for the local leaders, Christina and Danielle, since I'm used to doing virtual stuff for EDS Wellness. And we have Dr. Afrin here today, and what originally was supposed to be more of an interactive, smaller support group meeting turned out to be something that was much bigger because there's always an immense amount of interest in hearing what Dr. Afrin has to say related to EDS and a whole bunch of other things. And I'm always just so grateful to work with you, Dr. Afrin. Thank you for being here. So we originally did this for the group, but because there were so many people interested and registered for the meeting, we ended up turning it into a webinar format. So let me first apologize for those that were kind of thinking that your video and mic would be on and that this would be more of an interactive session. And we had to turn it into a webinar format, which the video and microphone are not on, and that you can communicate in the chat and the Q&A because of the number of people that were interested in these. I know Dr. Afrin has a presentation that he would like to give. Just so everybody knows also, whatever we discuss here, Dr. Afrin's presentation and the Q&A is for educational, informational purposes only. It does not discount or take away or take the place of your advice from a medical provider or seeking the care and diagnosis of properly from a medical provider, obviously. So please keep it in mind. Also, questions, we're going to try to answer and keep to the questions that were from the DC EDS group first, just because this event was for them. So we have received some of them via email, and I'm going to try to answer those first. And questions that are always brief are great because I can read them quickly. That doesn't mean that necessarily the answer is quick. So just be patient. I appreciate everybody being here. So before we let Dr. Afrin go ahead and start his presentation, I just wanted to give a brief overview of who Dr. Afrin is for those who do not know. Dr. Afrin is trained and practiced as an internist and hematologist oncologist at the Medical University of South Carolina from 1984 to 2014, and further practiced at the University of Minnesota from 2014 to 2017, coming to focus his interests on mast cell disease in the mid-thousands, I guess, 2000s. Since 2017, he has been developing an institute in New York for advancing care, research, and education in this area. He has published highly accessed articles about mast cell activation syndrome and a popular book in the field, which is Never Bet Against Occam, Mast Cell Activation Disease and the Modern Epidemics of Chronic Illness and Medical Complexity, right here. So thank you, Dr. Afrin, for being here. With that, and as long as all the technology is still okay and I'm not shaking, we're going to go ahead and let you get started.
Hey,
Are you ready to go, Doctor?
Yeah, let me share my screen. Tell me if this comes through okay. You seeing it now?
I'm seeing it now, and if anybody else would like to let me know if you all can see it, I can see the chat. I'm going to monitor the chat once you get started, Dr. Afrin, like I told everybody. So I can see your screen. Can everybody else see Dr. Afrin's screen? Yes, looks like it's a go. Okay. So I'm going to turn my microphone and my video off and then monitor the chat. Thank you, Dr. Afrin, and we'll talk once you're done.
Thanks, Kendra. Appreciate the opportunity and the interest from the Metro group. We've got about 60 minutes of presentation material here, give or take a few, and then maybe about 30, 45 minutes for questions. And for those of you who are who've seen my sort of MCAS 101 presentations before, and if you're expecting something new, sorry to disappoint you. So if you get bored partway through, you've been warned. So let's get started here. Going to provide an overview of the basic concepts regarding mast cell activation disorders, especially mast cell activation syndrome or MCAS. And because we are presenting tonight to the Metro EDS group, I'm going to spend just a little bit of extra time talking about the evidence of association between mast cell activation disorders and hypermobile Ehlers-Danlos syndrome or HEDS. And we'll wrap up at the end with a high-flying overview of the general approach to diagnosis and treatment of MCAS. I don't have any conflicts of interest to declare, none that I know of anyway, and I just want to be clear that any treatments discussed in this presentation that are not based on any clinical trials, because there have not yet been any clinical trials of any treatment in MCAS. So all of these treatment options discussed here are the lowest level of evidence, consensus viewpoint, or expert opinion. We'll talk first about what we've long known in the realm of mast cell disorders, the very common problems with allergic diseases and the rare disease of mastocytosis. And we'll, of course, spend the bulk of the hour on what's new in this area, namely mast cell activation syndrome. But I want to start first with an illustration of this extraordinarily complex disease. Keep in mind, this is not a new disease. It's a newly recognized disease, and it's in large part the extraordinary complexity and variability of the disease that has allowed it to go undetected for the centuries that we've had a medical profession, in spite of all the smart doctors throughout the history of medicine. So let's start by illustrating with my first couple of cases of this disease that actually presented with kind of polar opposite presentations. The first lady came to me with a relatively uncommon hematologic malignancy, a blood cancer that she had allegedly been diagnosed with, called polycythemia vera, which is overproduction of the red blood cells. And then the second patient in whom I came to recognize a mast cell activation syndrome, she had presented with exactly the opposite problem of a bone marrow that was failing to make red blood cells, a pretty rare hematologic condition called pure red cell aplasia. And as if the presentation of these two cases doesn't illustrate enough just how variably this disease presents, I'm going to quickly add in a third case, off in a totally different direction, a disease called burning mouth syndrome that I found in roughly my third patient who came to actually have a mast cell activation syndrome. So let's dive into it here. The lady with P. vera, she had been healthy for the first part of her life, but in her 30s began noticing a rash that would sort of wax and wane and migrate about different parts of her body with no clear rhyme or reason to it. And over time, she began developing various other symptoms. As you can see here, she underwent various evaluations from time to time, despite being a fairly stoic, hard-charging, independent, small businesswoman. But all these evaluations could not find any explanation for these problems. Finally, in 2005, she was in her early 50s at this point, and her fatigue had become so troubling that she went back to her primary care doctor, who of course checked a set of blood counts on her, and expecting to find anemia, that is low red blood cells, to explain her fatigue, he was surprised to find she had elevated red blood cell counts. And so she was referred to the local hematologist, who unfortunately pursued an insufficient amount of testing to pin down a diagnosis of P. vera. And based on that minimal amount of testing, he made that diagnosis. It was actually not the correct diagnosis, and he began treating her in the standard fashion for P. vera, which is to actually take blood out of the patient. Now, you'd like to think that if you give the right treatment for the right diagnosis to the patient, that the patient's going to get better, but she just kept getting worse in a whole variety of manners, as you can see listed here. Ultimately had to close her business Her local hematologist just kept taking more and more blood out of her, thinking he just wasn't treating her intensively enough. And she finally got to the point where she wanted a second opinion and came to my institution, and just serendipitously landed in my clinic. And it really only took about a minute's worth of history to realize she couldn't possibly have P. vera. I'm a hematologist. I know how that disease behaves, and her illness wasn't really behaving anything like P. vera is supposed to behave. So the question became, what do you have that can drive an increase in the red blood cell counts, but also cause all these other problems that really don't fit with P. vera? And right from the beginning, based on my training, I thought there were a number of features to her illness that fit with this very rare blood cancer called mastocytosis that I thought might explain this. But I did the traditional testing that we're taught to when we're looking for mastocytosis, and all of it was clearly negative, and repeatedly so. But over time, as other diagnoses were excluded, and it just continued to smell, so to speak, like mastocytosis, but it obviously was not a typical mastocytosis. With more and more reading that I was doing about the biology of the mast cell, I began learning about other esoteric testing that could be done to try to ferret out the presence of mast cell disease. I learned about this mast cell mediator called prostaglandin D2. Turns out to be pretty tricky to measure it, and I made every mistake one can make initially in trying to measure it, but finally, having fixed all the mistakes, I actually did find an elevated prostaglandin D2 level in her. And I was still thinking this was just an oddball kind of mastocytosis, because we really didn't know of any other mast cell diseases at that point. And to diagnose mastocytosis, like any other cancer, you have to find evidence of it in a tissue biopsy. So I sent her off, since I already knew at that point it was not in her bone marrow and it was not in her skin, because I had biopsied those areas and they were negative. I sent her off to the gastroenterologist because sometimes we find mastocytosis in the GI tract. Upper and lower scopings were done, biopsies were taken. The pathologist told me that on routine testing, everything looked normal in the biopsies, but I pressed him to do the special testing that's needed to be able to reveal the presence of mast cells. And this is what the tissue looked like with routine staining. This is a pretty normal picture of what the intestinal tract biopsies look like with routine staining. But with the special staining, the CD117 staining, it suddenly became apparent that a number of the cells which on the routine staining had appeared to be this particular type of fairly common immune cell called a lymphocyte. In truth, they were not really lymphocytes and actually were mast cells, as revealed by the brown stain here. And let's skip over this picture here. The bottom line is we had a diagnosis of what I could only call at the time atypical mastocytosis. I called her into the office and said, I think we have an explanation here. Now the question becomes how to treat it, because there was really no guidance in the literature how to treat this. And long story short, we talked about a lot of options ranging from simple antihistamines to other drugs, to trying a low dose of a drug which at the time had fairly recently been found to be helpful in very occasional cases of mastocytosis. It actually does not work in most cases of mastocytosis, but there were certain reasons in her why I thought it might make sense to try it in her. And so we started at the lowest dose, and after a week, we had her increase it. And in that first week, it really didn't do anything for her. But about half the way through the second week, she woke one morning and acutely realized, while just lying there in bed, having just woken, that all the symptoms she had been suffering for years, all of the disabling symptoms were gone. And actually, this slide's a little out of date. Her improvement has now sustained about 11 years. Her labs normalized, she resumed exercising and work. And then literally the day after I saw that improvement, I began consulting on another lady who came to me. I was her sixth hematologist that she was seeing for a problem that had been diagnosed several years earlier, pure red cell aplasia, where the bone marrow just stops making red blood cells. Sometimes we can identify the reason for that, but in her case, as in many cases of this disease, no reason was identifiable. She had proven refractory to all standard treatments for the condition. She was heavily dependent on blood transfusions to maintain even a still pretty poor level of red blood cells and hemoglobin in her body. And when I first saw her, I was struck by how many symptoms she had that really could not be attributed to just having low red blood cells. And thanks to everything I had learned in my efforts to try to figure out what was going on in my first patient, who allegedly had had P. vera, I began to realize that what was going on in this patient might just be a different variant of the same root problem. Of an atypical mastocytosis. And so I pursued the testing in her, and indeed quickly found the laboratory evidence to make a diagnosis. And by that point, there were some papers just beginning to come into the literature that were renaming this entity as a mast cell activation syndrome, since it was pretty clear that the numbers of mast cells that were found in the biopsies in these patients, although elevated above normal, were still nowhere close to what's typically seen in mastocytosis. And it was pretty clear that the symptoms were not coming from the number of mast cells in these patients, but rather from the inappropriate activation of these mast cells. We'll talk in a moment about what that means. So I began treating this patient, and instead of starting with imatinib, we started with antihistamines, and pretty quickly rendered her transfusion free just with antihistamines, but there was still more progress to be made. We tried a few other drugs, they did not help. Eventually tried a low dose imatinib and got a very nice improvement just a few weeks later. The condition unfortunately relapsed about a year later, and I was able to go back and retry another drug for mast cell disease that I had been unable to try initially, thanks to the insurer that she had at that time. But she had changed insurers, and I was able to now try a drug I could not try in her before. And once again, we got a very nice remission. Finally, my third case of this disease, off in a totally different direction. A lady came to me actually a few years before I saw the first two ladies. She had already been through a year of evaluation for fairly acute onset of severe burning pain throughout the mouth and somewhat less severe throughout the rest of the GI tract. Extensive evaluation was negative, except for finding on biopsy just a mild bit of chronic inflammation in the stomach, not surprising given her burning sensation there. And a very clever endocrinologist finally tested something called chromogranin A in her, and this is a marker for, these doctors learned that it's a marker for a fairly rare type of cancer called a neuroendocrine cancer, and it came back 100-fold elevated. Now, sometimes we can be fooled on that when a patient is on a proton pump inhibitor. That can drive the CGA level very high, but she was not on those drugs. And so she was sent to me for the possibility of a neuroendocrine cancer. Well, when I first looked at her, there was no question she was in pain, but she really didn't look like she had the sort of advanced cancer one would expect in somebody with a 100-fold elevated CGA level. But nevertheless, I didn't know anything else at the time that could cause an elevated CGA to that degree. So I went searching for the cancer that my gut told me was probably not there, and I was not able to find any cancer in her. I talked with a lot of other neuroendocrine cancer experts, and they all told me, well, the cancer has to be there somewhere because there's no other explanation for a markedly elevated CGA. And I would just have to keep repeating this $50,000 set of tests to look for this cancer every 6 months or so until I found it. And fast forward a few years, and well, first of all, I did not take that advice because it didn't make any sense to me. I considered a few other diagnoses in the coming years. They were all negative too. But when I started learning about mast cell activation, I began to realize that what was going on in this patient might just be another variant of the same root problem. So the blood and urine testing in this patient for mast cell disease turned out to be negative. But we went back to her old GI tract biopsies because pathologists, God bless them, they hang on to old biopsies for about 10 to 20 years in most cases. And we were able to reapply the special staining, and indeed we found the increased mast cells that allowed us to make the diagnosis. And with mast cell targeted treatment, the pain dramatically decreased essentially overnight. And I've been privileged to be able to consult on a number of other burning mouth syndrome patients since. And I mean, to be clear, BMS is caused in some cases by other diseases, but those other diagnoses are usually pretty evident in those cases. Most patients with BMS, there is no cause immediately obvious. And in all of those patients I've seen so far, we have been able to find and to effectively treat a mast cell activation syndrome. So clearly this is a disease that is capable of presenting in a highly variable manner, but it all boils down to the same root disease. So how is it possible that one disease can do all this, and could other weird, so to speak, presentations be possible? And we're going to answer those questions in just a minute. But let's talk first about what we've long known about diseases of the mast cell. First of all, the allergic diseases, very prevalent, thought to be present in about 10 to 20% of the worldwide population. We think the prevalence of these diseases has been increasing in the last few decades, and there are a lot of theories out there about that, but no clear answers yet on why that is. We know these are diseases that are conditioned by both genetic and environmental factors, and fortunately, most of the allergic disorders they cause discomfort from time to time, but only pretty rarely, fortunately, only pretty rarely cause death. But they unquestionably cause significant quality of life effects in millions of people. Now, the only other mast cell-based disorder that we've known about for a long time, about a century now, is the very rare cancer of the mast cell called mastocytosis. Now, this comes in a number of different forms. The skin-based form, cutaneous mastocytosis, was actually first described as this rare dermatologic disease called urticaria pigmentosa back in the latter part of the 1800s. And it was about a decade later before the mast cell itself was even first discovered. And then finally, a decade after that, it became apparent that urticaria pigmentosa actually was a malignancy of the mast cells in the skin. It took another half century before we started realizing that mast cells could cause not only skin disease, but internal disease. And that's around the same time we started figuring out that the mast cell contains a wide range of these very potent chemical signals we generically call mediators, like heparin and histamine and so forth. And tryptase is another one. And then it was the 1980s when we saw first published the concept that, you know, if there's this disease called mastocytosis, which features a cancerous overgrowth of mast cells together with inappropriate activation of the mast cells, that is, inappropriate production and release of the various mast cell mediators, then there also ought to be a disease in which there's just the inappropriate activation with little to none of the excess growth or reproduction of mast cells that is the hallmark of mastocytosis. But that was just a conception back in the 80s. Also in the 80s, we began developing classification systems for the different forms of mastocytosis. In the 90s, we finally identified a mutation, the KIT D816V mutation, which is found in the large majority of patients with mastocytosis. We began identifying some other laboratory methods for proving the presence of mastocytosis. And finally, in 2001, the WHO, the World Health Organization, came out with its classification system for mastocytosis, the different forms of that disease. And we've been using that classification system ever since worldwide. It's gone through a couple of updates since then, the last one in around 2017. And that same year, 2001, was also the year that saw the debut of imatinib, a real wonder drug for the treatment of chronic myelogenous leukemia, CML, a type of leukemia that previously had been fairly difficult to treat, as one could say about all forms of leukemia. But imatinib was a real game changer for CML. And it was only a year or two later when it started becoming evident that imatinib also worked really well in the rarest of the rare cases of mastocytosis, which did not have the KIT D816V mutation in them. And it was also in sort of the mid 2000s that we began to realize that the overgrowth of mast cells in mastocytosis causes illness only in even rarer, very aggressive or advanced forms of mastocytosis. Most people with mastocytosis, the cutaneous form and a systemic form called indolent mastocytosis, it's not the overgrowth of the mast cells that really causes much in the way of trouble in those patients, and rather it's the inappropriate activation of their abnormal mast cells that's causing the symptoms they're having. So this is the spectrum of mast cell disease we've long known. Think of it as a mountain where, and this is not quite to scale, but the great majority of the mountain are the allergic diseases in various forms. And at the very tip of the mountain is a tiny subset of patients who have mastocytosis in one form or another, cutaneous mastocytosis being about 10-fold more common than systemic mastocytosis. Cutaneous mastocytosis is mostly seen in children. Systemic mastocytosis mostly seen in middle and older age adults. So the entire mountain of mast cell disease features inappropriate activation of the mast cells, but it's only the patients with mastocytosis who additionally feature grossly inappropriate cancerous levels of proliferation of the mast cells. So now let's shift gears and talk about what we've learned about mast cell activation disease or disorders. Just briefly, again, the first hypotheses that this disease exists were published beginning in the 80s. In 2007, we saw the first case reports of this get published. Also in 2007, we saw the first study come out of the University of Bonn, courtesy of Dr. Gerhard Molderings and his team there, showing that in the same fashion that there were KIT mutations found in almost every case of mastocytosis, there also were KIT mutations found in almost every case of mast cell activation syndrome. But the KIT D816V mutation that's so common in mastocytosis is almost never found in MCAS, and instead it's quite a variety of other mutations in KIT that are found in MCAS patients. And with time, we began to realize that there are plenty of other regulatory genes in the mast cells besides just the KIT gene that also are commonly mutated in both mastocytosis and in mast cell activation syndrome. In 2010, we saw the first proposal for a terminology change in this area to, instead of calling it just mast cell disease encompassing allergy and mastocytosis and mast cell activation problems, it was proposed to reterm the area as the mast cell activation disorders or disease, based on the new recognition that first and foremost, what's going on in these patients to cause their symptoms are inappropriate activation. Now, there were a lot of, and this paper included the first proposal for specific diagnostic criteria for mast cell activation syndrome, distinguishing it from mastocytosis and just allergic phenomena. But there were a number of problems with this proposal for diagnostic criteria. And just a few months later, in early 2011, an alternative proposal was published, and full disclosure, I was the senior author on that proposal. Dr. Molderings was the first author. And there were some other authors too. The original group published a revision of their original proposal in 2012, but it was still quite problematic. That proposal was most recently updated in 2019 and was essentially identical to what had last been published in 2012. Meanwhile, the WHO in 2016 revised its diagnostic criteria for mastocytosis once again, but they understood the controversies regarding diagnosis of mast cell activation syndrome, and they probably wisely chose to make no statement regarding how to approach diagnosis of MCAS at that time. So this is the new landscape of the mast cell activation disorders as we presently understand them. The mountain is now seen as merely the tip of the proverbial iceberg, where everything above this waterline of fairly easy clinical recognizability are the various mast cell disorders we previously could pretty easily recognize, but submerged below this waterline of easy clinical recognizability is this far larger pool of what we can only broadly, non-specifically label at this time as mast cell activation syndrome. In truth, it's a zillion different variants of this disease that all exist within that big submerged bulk. And over time, I suspect we're going to learn better and better how to sort out the various different types of MCAS, but that's going to be a lot of work to come. So the entire iceberg is now recognized as featuring inappropriate activation, but it's just the tip of the iceberg that additionally features cancerous levels of proliferation of the mast cells, or what we call mastocytosis. We know that mastocytosis in its different forms is pretty rare. Mast cell activation syndrome, there's not been a whole lot of epidemiologic research in the area yet, but the best data I've seen published so far, again, thanks to the work from the folks in Bonn, suggests a prevalence of 17% in the general population. Yes, that is about 1 out of every 6 people. That sounds almost unbelievable at first, but as you come to know mast cell activation syndrome better and better, you begin to realize this estimate of 17% probably is not too far off the mark. That said, it's pretty clear that there's a whole lot more research to be, epidemiologic research to be done in this area. Let's briefly talk about some important features of normal mast cell biology. These are technically considered to be blood cells. They are born in the bone marrow from the stem cells, like all other blood cells. They leave the bone marrow pretty early after being derived from the stem cells. They circulate in the blood only briefly, and they come to reside in all the different tissues in the body. They're pretty sparsely distributed in most tissues. Where they're particularly abundant is at the environmental interfaces. So the skin, the respiratory tract, the GI tract, and the genitourinary or GU tract. And they're also pretty abundant in the walls of all vessels and nerves. And this is exactly where they need to be positioned in order to best serve their principal role in human biology, that of a sentinel. These cells react to various assaults upon the body, like trauma and infection, faster than any other types of cells in the body can react. Mast cells can actually react in sub-second time, as I'll show you an example of in just a moment. The mast cells have fairly limited capacity to move around, to mobilize once they have gotten into the peripheral tissues, and they typically last roughly 2 to 4 years before they have to be replaced. Their principal role is to manufacture and release as appropriate the various mediators. Different mediators get released when the mast cell is sensing different types of assaults. Another important thing to understand is this, this element of the mast cell called KIT. KIT is a key element of the surface of the mast cell. It's a receptor, and it is present in a great many copies on the surface of the mast cell. In fact, there are 10-fold more copies of KIT on the surface of every mast cell, about 50,000 copies of KIT on the surface of every mast cell compared to any other type of cell in the human body. And these high numbers of the KIT receptor, and not just any type of KIT, but normal KIT, that is unmutated KIT. Normal numbers of unmutated KIT are absolutely critical at the surface of the mast cell in order to support a wide variety of critical mast cell functions, including survival of the mast cell and activation of the mast cell. A complex cartoon more for medical audiences. Suffice to say that when KIT gets activated, it winds up then activating a wide range of internal mechanisms and pathways inside the mast cell that ultimately result in activation of the mast cell, the production and the release of various mast cell mediators. There are a great many different ways to trigger the activation of mast cells. The only mechanism that doctors are actually taught in their roughly 7 to 10 years of training are allergic type mechanisms based on this type of immunoglobulin or antibody molecule called IgE molecules. But in truth, there are lots of other ways that mast cells are known to be activated as well. Mast cells can react to a variety of physical stimuli. There also are a lot of other types of receptors besides the KIT receptor on the surface of the mast cell. The mast cell has receptors for histamine and antibodies like IgG antibodies. And this CRF is kind of interesting. That's corticotropin releasing factor, which gets released by a particular part of the brain anytime we are under stress. And it's well recognized that stress, either physical or psychological, is a potent trigger for mast cell activation. Mast cells can also be activated by opioids and various anesthetics and benzodiazepines and cannabinoids. I'm sorry, correction there. Mast cells actually they have receptors for benzodiazepines and cannabinoids, but they actually appear to be inhibited when exposed to benzodiazepines and cannabinoids, as opposed to these other receptors, which are activating receptors. Mast cells also have many of what are called toll-like receptors, and that's what allows mast cells to be heavily involved in the immune system's response to a wide variety of infections. A quick video here, courtesy of mast cell disease expert, Dr. Theoharides at Tufts University. This is going to show you what happens. This is a 3D video microscopy of a mast cell, and watch what happens when the mast cell gets exposed to a single molecule of this triggering mediator called substance P, which some of you may know as a pain-inducing substance. So I hope this will come through in the Zoom video. This is only going to be about 15 to 30 seconds, but you can see, I hope, the rapid outpocketings that are exploding out of this mast cell. That's how quickly the process occurs by which all of these stored up mediators inside the mast cell, stored within these granules inside the mast cell. This is how quickly the mast cell undergoes degranulation once it comes to be triggered. So the mast cell is capable of synthesizing and releasing many mediators, and by some counts, it's actually now been documented to produce and release more than 1,000 mediators, not just the tryptase and histamine that most doctors are taught in the 1 minute of teaching about mast cell biology and disease that they get across their 7 to 10 years of training. So my message from that is, go easy on your doctors who don't know much about mast cell disease. They are inescapably the products of their training, as I was until I began doing more reading, kind of by necessity, about all this biology that I had not been taught in my training. Now, in case you're getting bored listening to me, I'm going to start up at the bottom of the screen here, this ticker style thing. I hope this comes through in the in the Zoom here, and you're going to see crawling by this whole string of mediators that the mast cell in truth produces, again, well beyond just tryptase and histamine. So this will keep you occupied if you are getting bored listening to me. So the emerging understanding of mast cell activation syndrome, some people still think it's a pretty rare disease, but I'm running into more and more doctors who, upon coming to really understand what this disease looks and acts and smells like, they're beginning to realize, no, it has to be a lot more prevalent than just 1%. There's increasing evidence of critical mast cell involvement in a wide range of chronic inflammatory diseases whose causes have remained unclear despite decades of research. And, you know, it now becomes reasonable to question whether whether abnormal mast cells might, in one form of abnormality or another, might actually be the true root of what's going on. Maybe not in every patient with irritable bowel syndrome or chronic fatigue syndrome or obesity, but nevertheless, perhaps in a sizable proportion of the populations which bear each of these diseases. And we can similarly ask the question of whether there might be critical mast cell involvement in hypermobile EDS too. And we'll talk a little bit more about that in just a moment. Now, we think that what's actually driving the abnormalities, the abnormal behavior in these mast cells are various mutations. It's turning out that most of these patients have multiple mutations in KIT, as well as other genes as well. But the problem is we don't have the testing in any of the clinical laboratories anywhere on the planet yet to detect any of these mutations except for the KIT D816V mutation that is almost always found in mastocytosis and almost never found in MCAS. And I'm expecting it'll probably be about another 10 to 20 years before the tests for detecting these other mutations migrate from the research laboratories to the clinical laboratories. Just demonstrating here that a huge variety of mutations have been found all throughout KIT in patients with MCAS. And this probably goes a long way toward explaining why different mast cell patients clinically behave so differently from one another. Because if they have different mutations driving KIT to misbehave in different ways, then it shouldn't be surprising that they're going to clinically misbehave in different ways. So illustrated another way, let me put it to you this way. I mean, to go back to the original question, how can you have one disease that presents in so many different fashions? Well, do the math. We know that mast cells produce and release actually not just scores, but actually hundreds of different mediators. We know that any one mutation is going to result in the abnormal release of some number of mediators, creating some potential for multi-system illness and clinical variability depending on which mutation is present in that patient's dysfunctional mast cells. But it gets more complicated than this because we know most patients have not just one KIT mutation, but multiple KIT mutations in their dysfunctional mast cells. But it gets even more complicated because we know it's not just KIT that's mutated in most of these patients. It's multiple other regulatory genes in the mast cells that are mutated in most of these patients. But wait, it gets even more complicated than that because each mediator that gets abnormally released from the mast cell doesn't have just one effect in the body. Each mediator has its own unique and often quite large array of direct and indirect effects, local and remote effects, acute and delayed and chronic effects. So this is the manner in which one disease, so to speak, just in a million different variants, has such enormous potential for causing such a wide array of illness and such variability from one mast cell patient to the next to the next. So what does it look like in practice if it's so different from one patient to the next? Can you draw a big picture of MCAS? And it turns out you can, because there are certain broad themes to the mediators that get released from the mast cells to cause the various symptoms. First of all, inflammation is the universal constant in MCAS. All mast cell patients have chronic multi-system inflammation to some degree in some aspects of their bodies. Then there's a plus minus on the allergic phenomena. I say plus minus because some mast cell patients don't have any allergy to them. And then there are the unfortunate few who, honest to gosh, are suffering 24/7 anaphylaxis. And then everybody else on the MCAS spectrum is sort of in somewhere in between those polar opposite ends of the allergy spectrum. And then there's one more plus minus to MCAS, and that's abnormalities in growth and development in potentially any tissues in the body, what we medically call dystrophisms, abnormal growths. Fortunately, these are far more commonly benign than malignant, but it can be very difficult to recognize them as they're typically benign. They typically don't cause much trouble. And like most tissue growth, it's usually pretty slow. So it can be difficult to recognize the emergence of these problems. So folks with MCAS typically have symptoms beginning at no later than adolescence, often even childhood, occasionally even infancy. We often, but even though it emerges early, it typically goes unrecognized for decades. There often are escalations of baseline misbehavior of the mast cells shortly following major physical or psychological stressors. It's a multi-system disease. It is a perplexingly inconstant course. The level of tryptase circulating in the blood that is almost always very strongly elevated in mastocytosis almost always is normal in MCAS. And instead, we have to do testing for a variety of other mediators, which most of which actually are a good bit more challenging to accurately measure than tryptase. That does make for a challenging diagnostic process. These patients, very understandably, have usually seen great numbers of doctors over the years. They have acquired in their charts many different diagnoses, accurately labeling various superficial problems, but nothing really that establishes an underlying unifying diagnosis. And not surprisingly, they often get labeled by doctors and sometimes, unfortunately, even family members as it just being all in their head, it being somatic or psychosomatic. And that obviously can be very demoralizing. And unsurprisingly, with patients in this sort of a situation, they learn over time to stop reporting their symptoms because they learn it's kind of pointless, sometimes even counterproductive. So it's really important to the doctor to be very careful in extracting symptoms from these patients when they first come for evaluation to make sure the doctor really does gain an understanding of the full range of what's going on in these patients. Very quickly to go through symptoms, they're all over the map here, but by and large inflammatory. So a wide variety of constitutional issues, a wide variety of allergic or sensitivity or reactivity issues. And then, as you can see here, system by system by system, it's inflammatory phenomena. Inflammation, inflammation, inflammation. It keeps going system by system, inflammatory, inflammatory, inflammatory phenomena. I'm sorry I don't have more time to go into more details here. But again, system by system, it's inflammation, inflammation, inflammation. Same in the muscles, the bones, the joints. And remember, we said the skin, like the other environmental interfaces, is where we see an abundance of mast cells under normal circumstances, let alone abnormal circumstances. So it's no surprise that there are plenty of symptoms that are seen all about the skin, as well as the attachments to the skin. And not only the central nervous system, but also the peripheral nervous system as well. A wide variety of symptoms come about in the nervous system, again, all largely the result of various inflammatory forces being brought to bear on various aspects of the nervous system. And this gives rise not only to phenomena that we would classify as neurologic in nature, but also phenomena that we would characterize as psychiatric in nature. A huge variety of hematologic issues, such as either the high or the low red blood cell numbers that I showed you at the beginning of this presentation. Same for the white blood cells and the platelets, and for clotting tendencies. Some patients clot too much, some don't clot enough and have bleeding and bruising issues. You do a bone marrow biopsy in a mast cell activation syndrome patient, and it's usually normal. Which is another feature that really confounds many doctors in trying to diagnose what they think might be a hematologic disease like mastocytosis. The immune system is often affected in this disease, and there's a wide variety of fallout possible when the immune system is not working properly. The endocrinologic and metabolic issues are all over the map. The growth and development issues are all over the map. With regard to EDS, let's just spend just a few minutes here on this. In some portion of the HEDS population, the question arises, is that disease rooted in certain patterns of abnormal mast cell behavior causing abnormal assembly of normal connective tissue proteins into an abnormal conglomerate of connective tissue that behaves in the fashion we know for hypermobile EDS. So there have been a few small studies to date that have suggested an association between MCAS and HEDS. In other words, it's been observed that a good proportion of HEDS patients feature other symptoms beyond just their connective tissue issues, other symptoms that would be very difficult to blame on a connective tissue problem, but instead are pretty easy to blame on abnormal mast cells. But let's be careful. These studies, which generally are small studies, they are single center studies, they have a lot of deficits to them. And although they stir up a lot of smoke regarding a linkage between MCAS, a possible linkage between MCAS and HEDS, be careful, because smoke, of course, does not necessarily represent fire. Association is not the same thing as causation. Nobody has any idea yet whether there are certain forms of MCAS which truly can cause HEDS, and it is going to take an awful lot of additional rigorous, expensive research to be able to prove whether certain variants of MCAS cause HEDS. Is it possible that certain mast cell mediators might be the principal drivers of HEDS? There are certain proteins that are involved in the cohesion of connective tissue, molecules such as integrins and cell adhesion molecules, elastins, elastases. All of these molecules are among the many molecules made by the mast cells. But mast cells also make a variety of other mediators which can influence other cells to increase or decrease their production of all of these molecules as well. So it's not necessarily even if it is even if it does turn out to be the case that MCAS is at the root of some proportion of the HEDS population, it doesn't necessarily have to be the case that it's the abnormal mast cell itself that is putting out some connective tissue protein that is messing up the connective tissue to yield the HEDS appearance. And it's possible that the mast cell is merely, the dysfunctional mast cells in MCAS are merely releasing some mediator, which then is indirectly coming to have a downstream effect on the production, or on the overproduction, or perhaps underproduction of other molecules that ultimately wind up resulting in the HEDS appearance. So if mast cell-based mutations in mast cell activation syndrome are central to HEDS, what are the chances that existing sequencing technologies, what are called whole genome or whole exome sequencing, will find them? And those chances are actually pretty minimal, because most current whole genome sequencing technologies are only going to be able to find mutations that are present in about 20% or more of the population of cells that are sequenced. But mast cells actually comprise an extremely small proportion of the total number of cells that are present in whatever tissue sample you care to look at. Let's say you take a blood sample, for example. Mast cells are only about 0.02% of all of the white blood cells in that blood sample. So if standard sequencing technologies are not going to work to find these mutations, how are we going to make progress here? Well, we're going to have to sequence just the mast cells. And that's going to require first extracting the mast cells from the sample. And that can be done in at least a couple of different ways, as mentioned here. And then once you have reduced the sample to a fairly purified mast cell isolate, then you can apply the sequencing technologies to that purified sample to detect the mutations that are in at least some proportion of the mast cells in that sample. But again, there's no clinical sequencing lab anywhere on the planet that yet offers this mast cell focused sequencing. And this is sequencing that at present can only be done in various research labs. There actually are some HEDS research projects now underway that are performing whole genome sequencing, but it's my own guess that they're not going to be able to find these mast cell based mutations, because, at least to the best of my knowledge, none of these projects that are presently underway are yet performing this mast cell focused sequencing. If not already found by research labs, the mast cell mutational profiles, which may be common in HEDS, likely will quickly become apparent once this mast cell focused sequencing becomes clinically apparent, simply because physicians who are attending to MCAS patients likely will begin routinely ordering clinically available mast cell focused sequencing, primarily to learn of correlations between particular mutational profiles and effective therapies, that is, which therapies best treat which mutations. But at the same time, correlations between mutational profiles and various symptoms will fall out from that data too, and that may be one route by which we will be able to identify the mutations in the mast cells which are connected with causing the HEDS disease. And that knowledge may permit, it should permit, identification of mechanisms that drive the development of HEDS, and it should permit the design of rational treatments for that condition. So, with all this complexity to MCAS at present and such challenges in testing, how do we best diagnose this? Well, it falls back on the physician's best friend, a complete history and physical, and the physician needs to restore his faith in Occam's razor. Is it more likely that this complex patient with so many different diagnoses accumulated over the years really has had all of those problems develop independently of one another? Is that just all one big coincidence? Or is there in truth just one root issue that indeed is biologically capable of causing, directly or indirectly, most or all of the findings? And that, of course, is the more likely explanation. Physicians, unfortunately, for a lot of reasons, they lose sight of this over time. And when the typical patient comes in for the typical encounter, the physician winds up having to focus the 5 minutes he has on one particular superficial problem or another. But that approach usually is not going to be successful in coming to understand the presence of MCAS in the patient. This is the approach to diagnosing MCAS in, well, gosh, I needed to update that to 2021, shouldn't I? Sorry about that. I don't have time to go into the details here, but fundamentally, from the 3 boxes you see here, the physician needs to be able to at least develop a suspicion that MCAS is present. So he needs to learn that the disease exists, needs to learn some basics about how the disease behaves so that he can at least come to suspect that the disease exists. Then there's some initial testing to be done, and most patients then need to go on to the bottom box there, some additional advanced testing for various mast cell mediators, if that testing is available. And I well recognize that in many areas of the world, that testing is not yet available. We think so far from very preliminary research that most MCAS patients are probably going to have a pretty normal lifespan, and therefore it becomes all the more important to improve, to diagnose it accurately and to treat it effectively, to give them an improved quality of life in the decades they may have remaining in a normal lifespan. Treatment, I really am out of time to go through this and just want to highlight the general categories of treatment here. First of all, identify and avoid triggers as precisely as possible. Inhibit the production of various mast cell mediators to the extent possible. Inhibit the release of mediators, sometimes called stabilization of the mast cell, to the extent possible, to block the actions of any mediators that may have been released anyway, to block those actions to the extent possible. Let me be clear, mast cell activation syndrome is not a cancer, and so cancer type therapy, so-called chemotherapy or cytotoxic therapy, is rarely, if ever, needed for MCAS. In theory, there might be some role for stem cell transplantation, certain types of stem cell transplantation, but in practice, it probably would be very challenging to safely do this. And to my knowledge, allogeneic stem cell transplantation has not yet been done in even a single MCAS patient. And I would think it'd be very important for the safety of the patient to not pursue this treatment unless it's done in the context of a well-designed, rigorously executed and monitored clinical trial. And finally, what with all the downstream effects that the various mast cell mediators can have, that raises a number of secondary issues and comorbidities, which of course also need to be addressed. There's a variety of complementary treatments that sometimes can be helpful in some people with this disease, such as listed on these couple of pages, a couple of slides here. And some non-pharmacologic therapies occasionally can be helpful too. These pictures here just illustrate that it has been proven in the laboratory there are close connections, actually physical abutment between mast cells and neurons all throughout the body. So lots of interactions going on between the nervous system and the mast cells. One can come up with a million different ideas for pursuing research in the mast cell activation disorders. We really don't have time to go discussing all these and the many other possibilities. And let's just wrap up by noting that sort of the broad areas to be pursued in looking at the potential connections between MCAS and HEDS include clarifying clarifying what the association is here. We need larger and multi-center studies looking at the association. We need to do the hardcore research in the laboratory to investigate whether it's more than just an association, whether there's actual causation. And of course, if there is causation, we need to better identify which treatments targeted at the mast cells or perhaps other factors downstream from the mast cells might be able to improve or even correct the HEDS phenotype. So this is just a summary slide. I'm not going to go over any specific points here. We've talked about all this stuff. I'm going to bring it to a close at this point. Thanks for your attention, and I'm going to let's see, take this off of sharing the screen, and we will switch to, okay, that should have stopped the screen sharing and let me enable my video.
It did, Dr. Afrin.
And there we go.
All right,
good. Kendra.
All right, well, thank you, Dr. Afrin. That was wonderful. So before I just go further with the questions that we have and just try to get through as many as we possibly can. Obviously, bearing your time, I know it's 8:15. So I just first want to ask, there's a lot of people that have mentioned several times about, obviously, when you went through it quickly and some slides were of interest to more people. Is it possible to get certain slides if people want to get a copy of them, if they are interested in more information on certain slides? Okay.
Many people in the audience probably already know that there are copies of these slides in many different corners of the internet by now. And so therefore, it really doesn't matter if there's yet another copy somewhere.
Okay. And I will say to others too, that I have several, I'm absolutely happy to share links to Dr. Afrin's presentations and talks that he's done with me. That's, everything's a little bit different. I learn something different every time I listen. So, but if the slides are similar, I'm happy to give the recording links to those. And like I said, I could listen to this over and over and I learn something new every time. So, but the slides are similar. So, but thank you, Dr. Afrin, that would be great. And I'll try to make that available for everybody. One of the first things that I just wanted to reiterate or go back over, if you wouldn't mind, which is an easy transition. A lot of people in the group have GI issues. So can you go over again, if somebody is negative on a bone marrow test, they can still be positive on a GI sample or stain for Mast MCAS, is that correct?
That is correct. In fact, the vast majority of MCAS patients actually do not have any distinguishing findings, any diagnostic findings in the bone marrow. But many times we can find increased numbers of mast cells at various points throughout the upper and lower GI tracts. And so if a patient, I don't think a patient who's suspected of having MCAS probably ought to first go out and get endoscopies and biopsies done. That's an invasive procedure. And the fact is that most MCAS patients can be diagnosed through non-invasive, blood and urine testing. But nevertheless, many patients with MCAS actually have long had GI troubles, and in the course of enduring those troubles, they previously have come to be scoped and biopsied. And like I said, God bless them, the pathologists tend to hang on to old biopsies for 1 or 2 decades. And so it does become possible in many circumstances to contact the pathologist who performed the initial readings on those biopsies. He may well still have those biopsies in his archives. And those biopsies can be called back up from the archives and reprocessed with the special staining that is needed to reveal the presence of the mast cells in those biopsies. With the routine processing, the pathologist simply cannot recognize the mast cells that are in the specimens. They're there, but he just cannot recognize that they're there. It's only with the special processing that he can finally realize that, yeah, there are mast cells there, and he can determine whether it's a normal number or an abnormal number. Kendra, I lost your voice.
Oh, can you still hear me? Can everybody still?
Now you came back in.
Okay, sorry about that. And just to clarify, if, like, say Hopkins has somebody's old GI biopsies and they don't know how to stain them, I don't know how they are now, that is something that a mast cell doctor or you could actually make sure is done appropriately through you.
Yeah, actually, any pathologist knows how to do this work. They just have to be given a reason to do it. And it's that the gastroenterologists have not previously known about mast cell activation syndrome. The pathologists have not. Nobody has had a reason to do this special processing in the past. It was only the very rare patient in whom the doctors had a clear reason for suspecting mastocytosis. Those were the very few patients in whom this special processing was done right from the start. But with all the other patients, there was no reason to do it. So now, if there newly develops a reason to do it, then if that tissue is still present in the pathologist's archive, the pathologist can go back and revisit those old biopsies.
And the same is true also for GYN biopsies too, right? We can use endometrial biopsies. Is that right?
Not just endometrial, but any tissues in the gynecologic tract, the genital tract, and in the urinary tract. Some women with this disease come to have an awful lot of urinary tract discomfort that often is mistaken for recurrent urinary tract infections. But it's often not a matter of infection. It's just recurrent inflammation, non-infectious or sterile inflammation that's driving that discomfort. And for some of them, it leads them to a urologist who performs a cystoscopy, and biopsies are sometimes obtained from the urinary tract tissue. And those biopsies too can be re-examined with the special processing to look for mast cells that may be missed if only routine processing is applied to the tissues.
And I know that there's so many of us that are that story fits us very well. So along the lines of somebody that has GI symptoms, if they know that they are most of their MCAS symptoms come through in GI symptoms. If they're being treated for SIBO, is it possible that SIBO can affect MCAS and make the mast cell stabilizer medications either not work, or is it possible that treatment can issues such as SIBO affect MCAS as well as make most mast cell stabilizer medications not effective?
Yeah, I'm afraid I don't have any good answers to any of those questions. From what I and my colleagues have been observing, there likely are substantial connections between SIBO and MCAS. My personal suspicion is that SIBO is just another consequence of MCAS. But there is plenty of room for other views of the matter as well. And I'm afraid it's going to take many years, even decades of some pretty challenging research to untangle and more clearly define the relationships between SIBO and MCAS. I often see treatments for SIBO bringing modest to little benefit and virtually never any sustained benefit until the MCAS that likely is also present has been identified and reasonably well controlled.
All right. Another question that somebody asked is that abdominal aortic aneurysms are associated with several types of EDS, but there's been some research associating with MCAS. Can you kind of maybe decipher?
Very complex area, because let's be clear, although MCAS absolutely can drive a wide variety of vascular malformations, including aneurysms, there also are a number of other diseases, some of them acquired diseases, some of them actually inborn diseases, genetic or inherited or congenital diseases that can lead to the development of aneurysms. So the diagnostic assessment of a patient who has developed an abdominal aneurysm, or frankly an aneurysm anywhere, is just becoming an ever more complicated affair. It probably is fair to now add in an assessment for MCAS in any patient who's developed an aneurysm and who has the rest of the MCAS profile, that is chronic multi-system inflammation, plus minus allergic issues, plus minus other tissue growth and development issues. I don't know that I'd pursue an evaluation for MCAS in somebody whose sole health problem is an aneurysm. That would be a pretty unusual way for MCAS to operate.
All right, I'm going to read another question. Can you please explain how reacting to a single thing, I'm assuming this is saying, such as food or adhesive, can at times be systemic and cause long-lasting symptoms such as rash, hives, itching? Or is this more of a mast cell load thing, meaning like you react to one thing and then it seems to become just more systemic and kind of had long-lasting in terms of just now having, you know, rashes and hives? Or is it just a load? Reading the question as
yeah, I'm not entirely sure I understand the question. I think the bottom line is that patients with a mast cell activation disorder of any type have potential to react adversely and abnormally to virtually anything. And the patterns of that reactivity can vary to an extraordinary degree, not only from one patient to the next, but even within the same patient from one point in time to the next. And the reasons for that variability in reactivity in the individual patient from one time to another are poorly understood at present.
All right, and then along those lines of people reacting and presenting, there's somebody asked a really great question in the chat about when you talked about skin presentation in mast cell patients. If somebody has a darker pigmented skin, are there differences that you notice? Let me see if I can scroll up and make sure I'm asking the question correctly, but it was about the presentation, skin presentation in MCAS of people with darker pigmented skin. Does that change? Is there something you specifically look for more?
I think the only change is that it's obviously more challenging to recognize the presence of various skin phenomena in patients with darker pigment. I don't know what else to say about that. It's not that it can't be done, it's just that as challenging an evaluation as MCAS already presents the physician, I can easily see, I can attest from personal experience it's even more challenging in someone with a darker pigment. And let's not forget that it's folks with darker pigment who actually comprise the majority of the world's population.
Yeah, for sure. Very good point, Dr. Afrin. Okay, another question. And I'm just going to ask this quick before let's make sure I read the next one quickly. But in terms of people that have hives, if you itch a lot at night and you seem to get these small bumps that seem like bug bites, can hives be much smaller, or are they always these bigger welts?
No, hives can be of different sizes. And my personal suspicion is that this disease of urticaria or hives most commonly is a consequence of abnormal mast cell activation. It's possible for there to be some other types of diseases of the basophils or the eosinophils that might drive that, but probably most people who have troubles with hives, it's just another manifestation of a mast cell activation syndrome. But let me use this opportunity to make a point that mast cell activation syndrome, MCAS, is a very convenient term for packaging all together a wide variety of problems that are going on more or less in parallel in a given patient. But if the only problem one has is hives popping up from time to time, then it strikes me the more sensible approach to dealing with that condition is to diagnostically label it as hives or urticaria and to apply the standard treatments for urticaria. There's just no reason to invoke the much greater diagnostic and therapeutic complexity of MCAS when the extent of the consequences the patient is having from his or her mast cell disorder is a very confined, a very narrow set of troubles. Don't make things any more complicated than they need to be. You know the old saying, Kendra, the old guidance of KISS, keep it simple, stupid. Well, that applies in this area as well. If there's not a need to invoke the specter of MCAS, then don't, and your physicians will probably thank you.
Right. Well, yeah. All right. Well, before I go to a couple other questions, I'm just being cognizant of time, and I have so many questions. But of course, a big elephant in the living room, Dr. Afrin, is the COVID vaccine. Is there anything within reason that you feel comfortable commenting on, discussing?
Yeah. The fact is that patients who likely have moderate to severe MCAS were among those who were excluded by design from the COVID vaccine clinical trials. So we probably don't know a whole lot about how these vaccines are tolerated in folks with severe MCAS. Now, to be clear, the great majority of people with MCAS probably have a relatively mild form of it, and it's highly likely that many such, given the prevalence, the suspected prevalence of MCAS, it's highly likely that a great many people with mild MCAS, mild and unrecognized MCAS, probably were included in those clinical trials. And you are as aware as I am that the safety records in these clinical trials was terrific. There were very few safety problems seen in these clinical trials. But what to recommend to people with severe forms of MCAS is a real unknown. And I don't think we can, at this time, not having any data, I don't think we can offer any guesses that are any different from what we already have seen with mast cell patients' tolerance of other vaccines. I mean, I think it's pretty clear that patients who have severe and unrecognized, undiagnosed, untreated, uncontrolled MCAS not uncommonly do have problems tolerating various vaccinations, developing sometimes acute problems, sometimes developing quite sustained problems. And we don't know of any reasons yet to think that the COVID vaccines, even though some of them are using different technologies than some of the older vaccines, we don't know of any reasons yet to think that the COVID vaccines will behave any differently in this respect than any of the other vaccines that are given to folks. So I really can't provide any broad recommendations to the listening audience tonight. I think fundamentally each patient needs to have a careful discussion with his or her doctor about the advisability, the risks and the benefits. Obviously, nobody wants to have a bad reaction to a vaccine, but let's also keep in mind, this is a terrible infectious disease, is an extraordinarily contagious disease, and a large part of the reason why our entire world is freaking out about this disease is because such a high percentage of the patients who develop this infectious disease, compared to what we see with other infectious diseases, such a high percentage come to suffer a very severe course of this disease. So we have to keep in mind the contagiousness and the severity of this disease. But on the other hand, if an MCAS patient is going to live a normal lifespan, and if a vaccination is then going to induce a problem that the patient's going to have to live with for the rest of his or her life, that's a tough set of factors to try to balance and make a decision whether to get a vaccine or not. I can very easily see how different patients in pretty much the same condition would come to completely opposite conclusions on that. And that's not to say that one conclusion is right and the other is wrong. You know, the old saying about different strokes for different folks. And oh boy, does that apply in this situation. So I'm afraid I just can't responsibly say anything more in the absence of any data.
Right. What about pre-medication, though, for those of us that have reacted to previous vaccines before? And
some mast cell patients come to find that increasing their mast cell targeted medications shortly before they're going to be subjected to a major stressor. And let's not kid ourselves, any vaccination is a major stressor on the immune system. I mean, that's by design.
Right.
So some mast cell patients come to find that temporarily increasing their mast cell targeted medications prior to being subjected to a major stressor actually, like a surgical procedure, for example, can help them get through that procedure with less trouble. That said, the degree of variability from one mast cell patient to the next is so extreme that I don't feel I can responsibly provide any suggestions at all regarding specific medications that the average person at large should be taking before or following a vaccination or any other procedure. Every patient is different and requires careful consultation with the managing physician to decide what course hopefully will be the best for that patient. And everybody has to keep in mind that the doctors are operating with a whole lot more that's not known than what is known, not only about the vaccines, but also about the infectious disease itself, COVID-19, and of course about MCAS. So please try to go easy on your doctors. They're doing the best they can with the training they've been given and the experience they've managed to accumulate.
Right, and as we're going through this. All right, here's a couple other just simple questions. They may or may not be simple. Is there a reason why somebody would react to all forms of coconut or all types of oil? Is there a category for all those things that they fall under? Or is there a category that all those things fall under? So is there a reason why somebody would react to all forms of coconut or all types of oil? Or is there a category that all of them fall under? Sorry, I repeated the question.
Again, different patients are going to develop dysfunctional mast cells that are going to inappropriately react in different patterns. Some people will react to all forms of coconut or all forms of this plant or that plant. I have some patients who react, for example, to cellulose, a very common constituent of most plants on the planet, but some patients react to cellulose that comes from cotton, but not cellulose that comes from, say, wood trees. I have other patients with exactly the opposite reactivity. They react to cellulose derived from wood, but they tolerate cellulose that comes from cotton just fine. And I don't doubt that as the decades go on and as more research in the laboratory gets done, we will eventually figure out precisely what is going on at the molecular level in the dysfunctional mast cells in these different patients that leads to these different patterns of misbehavior. But we are just decades away from having that knowledge.
Unfortunately, I think all of us would wish that research would just be solely on mast cell stuff, because it seems like if we could all just figure out how it's related to our symptoms, I mean, the world would all be better, Dr. Afrin. So
there's
somebody
a lot
asked,
of other disease out there too that has nothing to do with mast cells, and the
that's
people
right,
suffering those diseases probably want to see research in those areas too.
for sure. All right, here's just a basic question. Why does anaphylaxis happen? Isn't that maladaptive?
Of course.
Again, I'm just reading the questions.
It is usually maladaptive, not quite always, but anaphylaxis is in essence an extreme degree of mast cell, of acute mast cell activation in patterns that drive certain symptoms, most commonly a swelling in the upper airway that makes it impossible to breathe or to swallow. But that's just one particular pattern and one particular degree of severity across a humongous assortment of patterns of reactivity and a tremendous assortment of degrees of severity that we see in reactions across different mast cell patients that are who are being exposed to different triggers. And let me point out too that, I keep saying that it's best to identify one's triggers as precisely as possible and then do one's best to avoid them. But let me also acknowledge this is actually pretty hard to do. And the fact is, the great majority of mast cell patients will not be able to identify what the specific trigger is for the great majority of their flares. But nevertheless, if they don't at least try and continuously keep trying to identify what the triggers are, then the outcome's going to be a foregone conclusion, because they will continue to keep exposing themselves from time to time to various triggers, and they will continue suffering flares almost regardless of what medications are on. It turns out to be fairly challenging, actually, for any drug to gain good, sustained control over dysfunctional mast cells when the patient is simultaneously and persistently ingesting or otherwise exposing themselves to a trigger. So step one in managing this extraordinarily complex disease must always be identify your triggers as precisely as you can and do your best to avoid them. You know, over time, as you come to gain better control over the disease, many mast cell patients actually do manage to regain some measure of tolerance to things which previously had become intolerable, but that's over time. You know, to begin with, they need to identify their triggers as precisely as they can, down to the individual ingredient level, if at all possible, and then do their best to avoid them. Many mast cell patients, for example, wind up being reactive to certain specific so-called inactive ingredients, otherwise known as excipients, in their medication products. For example, the various fillers or binders or dyes or preservatives. And if a mast cell patient can figure out that it's a particular excipient, like, we talked about cellulose before, microcrystalline cellulose, or maybe red dye number 40. If that turns out to be a real trigger for a given patient, then, oh my goodness, that's a huge discovery for that patient, because many of these excipients get incorporated into thousands of different medication products. So once a mast cell patient finally pins down one of his or her triggering excipients, then the patient and the doctor and the pharmacist want to do everything they can possibly do to scrub that trigger out of the patient's regimen.
Yeah, for sure. There's so many different kinds of triggers, smells, even sensations on the skin.
Well,
We eat. Yeah.
you know, smells are odors, and odors are the product of various chemicals, aerosolized chemicals. And chemicals are substances. So whether
Yeah.
it's a liquid substance or a solid substance or an aerosolized substance, substances
Yeah.
can be triggers. Certain physical activities can be triggers. Certain physical forces can be triggers. It's different in different patients.
Yeah. What would be, I have a couple more questions. I have a lot of more questions, but I'm trying to be cognizant of your time. Are you comfortable going to 9, Dr. Afrin?
I
That's
think
about
we'll need to close it
14
out.
minutes.
Yeah, I think we'll need to close it out at 9.
Okay, sounds good. I'm going to first start with this, is a very important question. What is the best, most succinct resource that you can recommend to give to primary care physicians as an overview of MCAS? If you're trying to provide something to your doctor, if they're willing to read it.
Yeah, it's a great question. I'm pretty sure that every doctor who has familiarity with MCAS will probably have a different answer to that question, because I don't know that there's any resource out there that is truly ideal. I will tell you, there are a number of review articles about MCAS in the medical literature, which are fairly easy to find if you go to Google or you go to PubMed and you put in, you search for mast cell activation syndrome review. And probably any of those review articles would be reasonable to provide a doctor who's new to this area to start the learning process. I also published a paper back in 2017 called Characterization of Mast Cell Activation Syndrome that provides an overview and a number of details regarding symptoms and lab tests and so forth. Honestly, there are a lot of different reviews that approach the subject from different angles. I don't know that there's any one that's best, and maybe the best way for the arbitrary doctor is just to give that doctor a small list of review articles and let the doctor, glance at the different articles and decide which one is going to best suit his or her reading style.
What about trying to find a doctor that treats MCAS or is
probably the most important, probably the most important question of all, because the fact is, here we are now, 14 years now since the publication of the first case reports of MCAS, and it remains the case that virtually no doctors have even heard of this, let alone have developed any significant familiarity with it. So the fact is, the vast majority of patients out there are not going to be in proximity to a doctor who has familiarity with this. You can certainly start with your existing physicians and ask them if they know about it or if they know of any other doctors who they think might know about it, and follow those leads. Anybody listening who wants to message me and ask if I know of any doctors in their area, they're welcome to do so. But if I get flooded with such inquiries, please be aware it will take me quite some time to respond, because I'm already flooded every day with emails and inquiries of various sorts. But I'll do my best to help those who are listening. Honestly, the fact that there are so few doctors at present who have good familiarity with this means that the great majority of patients who come to suspect they're having this, they are going to be dependent. They're not going to be able to get, at least not immediately, into the hands of any of the few doctors, the several dozens of doctors around the globe who now know the disease pretty well. And instead, they're going to be reliant on their local doctors. They're going to need to find a local doctor who's willing to learn about this and willing to at least try to help the patient with this. And I'm aware that most doctors, for various reasons that actually are pretty legitimate, they're not willing to learn about this. They're not willing to try to help. They've got other priorities. And again, that's not illegitimate. But it's also been my experience that most patients, regardless of whether they're in an urban or a suburban or a rural area, regardless of whether they're in the US or any other country, most patients, if they are sufficiently diligent in canvassing the various physicians that are within a drivable distance, most patients who suspect they have this actually are able to eventually identify some relatively local physician who indeed is willing to learn and willing to at least try. And it is going to take patience and persistence on the part of the patient to find those helpful physicians. But if there's any physician out there who wants to learn more about this and is just not quite sure how to go about doing it, the patients are more than welcome to put those physicians in contact with me, and I will be happy to provide whatever guidance, counseling, coaching, whatever guidance other physicians may want to learn about this. I'm happy to do that. The more physicians who come to learn about this, the better. Frankly, every physician I've known who's come to understand this disease, they've then told me a few months, maybe a couple of years later, oh my goodness, I've been seeing this left and right all day long, every day, my whole career. I just couldn't previously recognize it for what it is because nobody had ever taught me that it exists, and nobody had ever taught me what it looks like. But now that I can recognize it, now I can diagnose it because there is testing for it, and I can treat it. And oh my goodness, these people who most of whom we thought were psychosomatic, no, they're not psychosomatic. And yes, we actually can find treatment which finally helps them, even though most of them have been mysteriously unwell for years to decades.
Yeah, for sure. I can definitely understand that personally myself, and I'm true testament to why you're here, Dr. Afrin. And there's so many thank yous in the comments, and I personally say thank you too, because it's amazing to have providers that listen to us and are willing to take the time to care and to try, even for something.
Let me also offer, because actually before we started the session tonight, one of the very first questions that I saw pop into the Q&A or the chat room was from a patient in Australia. Believe it or not, you have at least one person listening from Australia.
I saw that. I did see that.
Where to go in Australia to find expertise with this. And because you had touched on the subject of how to find other doctors, and because somebody tuning in from Australia, which is completely the opposite time zone from us.
Sydney, Australia.
Let me provide that patient a tidbit. There actually is, I actually know several doctors in Australia who are coming to develop familiarity with this, but one doctor in particular is kind of becoming the leader in Australia in his familiarity with this disease. Dr. Mark Westaway, Westaway, Dr. Mark Westaway in the Brisbane area. And even if you can't go to see him, I know Australia is a pretty big country like the US is, but there's a possibility he might be able to do telemedicine. There's also the possibility he may know other doctors in your area who are beginning to develop familiarity with MCAS.
Dr. Afrin, there's somebody else from Australia as well as coming that's actually in Brisbane. Yeah, that's pretty amazing. Wow. So welcome. And I think there's a couple other people from other countries too. I don't know if they've commented, but Dr. Afrin, you reach the global. So this is awesome. It just makes everything so worthwhile. So I did put the comment, Dr. Mark's name in there, and everybody's saying thank you, Dr. Afrin. A couple more questions before we go. What about your basic itching? Is there anything you can do for itching if you react to both nasocrom and Benadryl cream? And I would like to also add to that, why do people tend to itch more at night, or at least some people do? Is there
actually the activity level of mast cells, even normal mast cells, is known to vary at different times of the day, a so-called diurnal variation in natural normal mast cell activation. But as far as what to do about it, you actually raised a couple of issues. Number one, if you're reacting to cromolyn or to Benadryl cream, let me just point out that cromolyn and diphenhydramine, the drug that's in any Benadryl formulation, usually are very well tolerated drugs. So if you're having reactions to any products containing those drugs, you have to seriously consider the possibility that what you're actually reacting to is not the drug, but rather one or more of the excipients, the so-called inactive ingredients that are mixed in that formulation. I've learned to hate the term inactive ingredients because sure, those ingredients are inactive for most people who use that product, but for a mast cell patient, mast cell patients can potentially react to anything. So I would rather we learn to use the more generic term of excipients. And as far as what other medications can help with itching, honestly, beyond the antihistamines, I have learned that it is the biology of this disease is so complex that it becomes possible for virtually any mast cell targeted medication to bring about some degree of control in virtually any symptom from the disease. Not a week goes by where I don't have a patient coming back to me in follow-up, having started, a month or two earlier, some new medication for the disease, and I ask them, how's it going? And they say they're doing better. And I say, well, tell me specifically what's better. And in the list of symptoms they tell me that have improved are certain symptoms I never would have expected to be improved by that drug based on what I have been taught and what I have read as the basis, the mechanism for action for that drug. And yet the symptom is improved. So clearly there has to be some way that the drug is bringing about improved control over the patient's mast cells to reduce that symptom. We just are nowhere close to understanding the science of it all.
Yeah. And I think every one of us that has found something that works is different than the next person. Like you said, it's just really different.
A given drug A might be wonderfully helpful for a given symptom 1 in one patient, but in the next patient who superficially might look very similar, that same drug A may do nothing for symptom 1 and instead remarkably help symptom 2, which was not helped at all in the first patient. And again, there has to be a real biological reason why the same drug is having such different effects between the different patients. But we just don't understand the science of this nearly well enough yet to understand why different drugs are having different effects in different patients.
I'm adding this one question in. Why do benzodiazepines seem to work for some people, for like itching and pain and those things?
Because it turns out,
and
I think we're going to need to bring it to a close after this question. It turns out that, all doctors are taught that the manner by which benzodiazepines work is by engaging the inhibitory benzodiazepine receptors that are present on the surfaces of all neurons. So when you take a benzo and it distributes throughout the body via the bloodstream, it comes to dock with the benzo receptors on the neurons. And this comes to inhibit neuronal activity. And this tends to tamp down anxiety and certain other neurologic or psychiatric symptoms. Well, it turns out that there also are benzodiazepine receptors on the surfaces of the mast cells. And in the same fashion as how benzodiazepines dock with the benzo receptor on the neurons and thereby inhibit neuronal activity, the same thing is going on in the mast cell, that the benzos dock with the benzo receptors on the surface of the mast cell and thereby inhibit, or at least have potential to inhibit, various aspects of the activation that's going on in the mast cells. So benzos can help not only reduce anxiety in mast cell patients, but they sometimes can also remarkably reduce a wide range of other symptoms too in those patients, symptoms that are coming about not from the activation of the neurons in those patients, but rather from the activation of the mast cells in those patients.
Based upon your early part of your presentation where you showed how closely mast cells sit to the neurons and the nerve cells, I mean, it's no wonder that these things work, that, like you said, these medications help symptoms that you wouldn't necessarily ever think that a certain medication would, based upon where mast cells are in our body and just the complexities of all of it. And of course, there's so many questions that we didn't get a chance to answer, but that is always the way that it is, because, you know, obviously this is such a huge topic of interest for so many of us. And we just appreciate your time, Dr. Afrin, and your willingness to help people, and your willingness to answer as many questions as you comfortably can, and you're willing to help other providers. And we're thank you so much. And I'm just appreciative of you working with me whenever I ask you. And you're always very nice and kind, and to help those that I work to help. And so thank you so much. And the recording will be out. Dr. Afrin said that we could also work on sharing his slides. So I'll work with Dr. Afrin on that, and also help get his contact information for his office. So thank you, Dr. Afrin. Thank you so much. It was wonderful to see you. Happy New Year, everybody. And
Thanks to you
thank
and
you.
Metro. Appreciate the opportunity.
Yeah, thank you to the Metro DC, EDS, and HSD group. And we look forward to seeing you all, everybody, next time. Thank you again.
Good evening.